Okay, so we'll start off with a little bit of a recap of last week. I think the number one thing that we saw from the presentation was that vaccines help. So please get vaccinated. Um, the differences between infections and people who are vaccinated and the outcomes are striking. Also, use monoclonal and antiviral therapies as available and make sure that you are following current recommendations. And then our third key takeaway was to make sure that you are familiar and that your staff are trained on atypical presentations of COVID. Last week, we learned about some of these atypical presentations: GI distress, loss of appetite, falls, and confusion. Okay, on to the next slide. So we're going to start out as we often do with our echoes.
I just get to kick it off with like a 1-minute moment. And notice we have been talking about language. It's just one element of changing institutional culture. And I'd love for each of you to let your brains think about why words matter. And I think we all would have a different story to tell, perhaps. I'll take the next slide, please. And being amongst a lot of researchers and people who care about research, I thought I'd show you a study regarding older adults, regarding words, and regarding their memory. So I doubt it's any big surprise that in a study, there were two groups, and one group heard really positive words about aging. Isn't this cool? This is kind of where we're headed. So think of words like wise, alert, sage, and learned. And then another group heard negative words about aging: decline, senile, decrepit, dementia, confused. Who can guess who had a better performance on a memory test? Can you believe it? Like, oh, you get older and your memory gets worse, and you get decline and senile, and now we're going to give you a memory test. So it's no surprise the memory performance was worse when they heard the negative words. No surprise it was better when people heard the positive words about aging. And then a side effect, I suppose, of this research study was that the researchers timed the people, I guess, walking out of the building after the test. And guess who even walked slower? The people that heard the negative words about aging. And they denied it.
So our objectives for today: describe the prevalence of mental and behavioral health issues in nursing homes, identify behavioral and psychological symptoms of dementia, BPSD, and potential triggers, and describe the progressively lowered stress threshold model, or PLST. And lastly, review non-pharmacological person-centered interventions for behavioral expressions in dementia. And kind of dovetailing on Carmen's kind of culture change moments and the importance of language, I'm going to encourage you to use the term behavioral expressions in dementia, and hopefully that will become a little bit more apparent as we to kind of understand the context. And you all live and breathe, working in these communities, but to understand the prevalence of mental and behavioral challenges in nursing homes. So 65 to 90% of residents have a mental or behavioral health problem, and up to 50% of them suffer from depression. And I think that that's probably even highly under-recognized and diagnosed, and certainly undertreated. And nearly 60% of residents have dementia, and many with a high prevalence of these behavioral and psychological symptoms that we discussed. But I think even more poorly recognized, and which is becoming a major challenge, and it's beyond the topic of today, but I just wanted to highlight it. And this is data that's now 10 years old, but there's more mentally ill living among the older adults in facilities, in these care communities. And this was back from data, looks like 2002 to 2008. And nursing homes back then had seen a 41% increase in the young and middle-aged residents with mental illness. And I think that this is really kind of changing a lot of the cultures in these communities, and it's important to kind of be mindful of how we are navigating behavioral health and being mindful to everyone's needs. Next slide, please. And so I think, the focus more for today is on dementia. And I think it's helpful to put yourself in the shoes of the person with dementia and see the world through their eyes. And so if you understand what's kind of happening in their brain, so this is just a little mini pathophys, if you will. But as you know, dementia is caused by neurodegeneration, or the damage and death of the brain's neurons. And depending on the types of neurons and the brain regions affected, the form of dementia differs. So for example, there's frontotemporal dementia, which mainly affects the frontal and temporal lobes. And so in frontal dementia, the front of our brains is kind of where we have our executive functioning, our ability to organize, plan, sequence events, and also have a filter so we don't say inappropriate things or do inappropriate things. And oftentimes folks with frontotemporal dementia will have more behavioral issues that start first rather than the memory issues. And then Lewy body dementia affects a different part of the brain and also has different types of symptoms. So this affects more of the frontal lobe, but also some of the motor cortex. So we have a little bit more of a Parkinsonism type picture. And lastly, Alzheimer's disease. And Alzheimer's disease results in widespread degeneration with damage to the hippocampus. And when you damage the hippocampus, this is the part of the brain that's essential to memory formation and also produces new neurons. And so the loss of brain tissue results in, as you can tell, a shrunken brain, enlarged ventricles, and more space between the folds. Next slide, please. And so if you think of symptom progression in Alzheimer's disease as this person's brain shrinks and plaques and tangles and start to build up, you start off with mild cognitive impairment in the early stages to mild Alzheimer's disease, where it's just simple forgetfulness, short-term memory loss, repetitive questions. Folks don't tend to land in a move to a nursing home until more moderate or severe stages, where they might have aphasia or language difficulties, the poor impulse control or the dysexecutive symptoms in terms of being able to organize and plan and sequence their day. They start to have activities of daily living impairments, difficulties with toileting, bathing, dressing. And then in more severe Alzheimer's, that's when you get the altered sleep patterns, the agitation, and dependence on eating, bathing, dressing, feeding, and so on. Next slide. So I'd like to see if you can put in the chat, what are some of the most common behavioral and psychological expressions you observe in residents with dementia? Anger. And Kelly, I fully agree that those with mental illness are definitely living longer, and many go on to develop dementia, and so the management is different. So anger, combative, sadness, wandering, confusion, impulsiveness, wandering, calling out for help, verbal noise, wandering, fear, difficulty expressing emotion, comes out as combative or angry, insomnia, refuse care, takes off clothes, touching private areas when in the lounge, peeing in odd places. Most definitely. These are all behaviors that I have received consults for sure. So next slide, please. So I think it's helpful to sometimes to create these symptom clusters to help understand what might be driving these behaviors. So there was a lot that many of you identified, kind of the psychomotor agitation, because when I get a consult and someone says, well, they're agitated. Well, that's a symptom, not a diagnosis. We need to kind of describe it. We need to unpack it. Are they walking aimlessly? Are they pacing? Are they following staff? Are they restless? Are they rummaging? Undressing? Do they have sleep disturbances? Or are they having psychotic symptoms, hallucinations, delusions, misidentifications? And then aggression. And this can be manifested as aggressive resistance, perhaps during care, or actual physical aggression or verbal aggression. And again, that dictates perhaps the level of intervention that might be needed. Or do they have depressive type symptoms? Are they sad, tearful, hopeless, anxious? And then oftentimes in dementia, apathy is very prominent. So they might be withdrawn, lack of interest. They need cueing to engage in meaningful behaviors and participation in activities. You might think that they're just isolative, but they might not actually understand that, hey, there is a calendar and there's these activities going on, but they need cueing and prompting to go actually attend them. Next slide, please. So how many of you all, if you wouldn't mind, it's going to be hard to see, but hand raise, the progressively lowered stress threshold model. How many are you familiar with that? I'm trying to thumb through the pictures of folks. Okay, go ahead. So the basic principles of the PLST are that dementia leads to impaired ability to receive, process, and respond to stimuli. And these impairments worsen as the illness progresses. So as you can imagine, in persons with dementia, their stress threshold is lower. And as a result, they have increased difficulty tolerating stressors as the disease progresses, as the brain shrinks, as the plaques and tangles accumulate. And that results in these challenging behaviors that many of you described. And some of these behaviors result from losses associated with the disease itself, and others result from environmental stress. Next slide. So now I'd like to share with you a case. This is Mr. Jones. It's not his real name, but this was actually a real individual with whom I worked many years ago. And actually, it was a fun scenario because this gentleman was one case that we ended up getting interviewed on NPR because I helped this one facility go from a 2-star to a 5-star, and we reduced their antipsychotics from 25% to 0, and we sustained for over 3 years. And this was just a nice example of kind of the importance of being creative and understanding agendas that are driving behaviors. So let's talk about Mr. Jones. So he's an 84-year-old male with moderate Alzheimer's disease who ambulates with a fairly steady gait. He does not sleep well at night, and he's often observed wandering in and out of residents' rooms during the middle of the night. Sometimes he's even found checking windows and standing at the foot of the bed of sleeping residents. This is particularly upsetting to the female residents. The family of one of the female residents has called to complain to the administrator. When the staff take him by the arm to gently escort him out of the room, he gets verbally and physically aggressive. Does this sound familiar, folks? Next slide, please. So what stands out for you in this case? I meant for very familiar, Cindy said. Yes. So, here's someone with moderate Alzheimer's disease. He has a fairly steady gait because you always want to be concerned about falls. He doesn't sleep well at night. He's wandering in and out of resident rooms, checking windows, standing at the foot of the bed. It's upsetting. There's complaints. And then the staff, grab him, and that results in verbal and physical aggression. Next slide, please. And I want to argue that behaviors are not problems. Behaviors represent unmet needs. And yes, as Dr. Jurovich says, physical touch in Alzheimer's is a trigger, very much so. And you have to kind of put yourself in their shoes and what's happening with their brain and that lowered stress threshold. But these unmet needs, and go ahead, Chris. So all behavior has meaning, and it's up to us to figure out what it means. And this is what I love about what I do, is it's trying to be a good detective. Next slide. So these unmet needs can come from within the person and or stressors in the external environment. And this need-driven behavior model assumes that for multiple reasons, something to do with the dementia or something to do with the environment, that behavior is the person with dementia's way of communicating that they have a need or needs not currently being met, and therefore characterizes the behavior as an expression of need. Next slide. So Zoom poll. What should the staff do for Mr. Jones? And our unmet need driving his behavior. And this is the fun part, I think, of what we get to do. It's very person-centered. But unfortunately, that's not what happened. And again, remind you, this was about 10 years ago. So the nurse called the on-call doc who didn't know Mr. Jones, and the doc prescribed risperidone 0.25 milligrams QHS for dementia with agitation. And of course, not what we want. And so Mr. Jones revisited. Over the next few days, Mr. Jones's wandering actually increased both at night and during the day. He seemed anxious, irritable, restless, and was frequently observed pacing the hallways. And when staff would try to stop to speak with him, he had a difficult time standing still, and he'd shift his weight from foot to foot. And when he tried to sit down to rest, he crossed and uncrossed his legs, seemingly very anxious and unable. Slide, please. He had akathisia from the Risperdal, and it needs to be discontinued, and refer him to geriatric psychiatry and neurology. And this is when I came in. Next slide. So what is akathisia? Akathisia is a movement disorder that can occur as an adverse effect of antipsychotic medications. It can also be associated with antidepressants, calcium channel blockers, antiemetics, anti-vertigo drugs, and sedatives used in anesthesia. And it usually develops within the first 2 weeks of antipsychotic therapy. It's also more likely if you start with a high dose or suddenly increase the dose or stop the medicine abruptly. And so what does it look like? It manifests as this psychomotor restlessness or inability to remain still. Individuals feel this intense sensation of unease or an inner restlessness, like they're going to crawl out of their skin. And it usually involves the lower extremities, and that's what results in this compulsion to move. The person appears restless, pacing, rocking, marching in place, shifting position, crossing, uncrossing their legs. They're just fidgety. And internally, they have this inner sense of restlessness again, and which manifests as this feelings of extreme anxiety, irritability, panic, discomfort. And this can lead many, if it's unaddressed, to dysphoria, depression, and even suicide. So it's really important to be able to recognize this. Oftentimes people think that this is just agitation getting worse, and the inclination is to actually increase the antipsychotic, which is the worst thing you can actually do. Next slide, please. So again, this culture change moment of changing our language from the behavioral and psychological symptoms of dementia to behavioral expressions in dementia. Because as we've talked about, that these are expressions of unmet needs and frustrations. And it's our job to figure out what's going on. And because these unmet needs, these behaviors have purpose, function, and meaning to the person. They could be either attempts at communication that can be explored with validation. They could be attempts at gaining control over unwanted or threatening situation. Or they could be attempts at preserving their dignity, identity, or personhood. So again, these are barometers for tolerance to stressful stimuli that it's important for us to figure out, what's the agenda or the need driving the behavior. Next slide, please. So there's a myriad of factors that can contribute to behavioral expressions, from the physical domain, emotional domain, environmental domain. And in the case of Mr. Jones, there was the disease itself, the illness. There could be potentially an illness infection. You always want to rule out delirium oftentimes when there's a sudden acute change in behavior. He could have pain. He could be hungry, thirsty, constipated. Again, drug effects. Oftentimes over or understimulation in their environment can lead to behaviors. And an invasion of personal space. So he was invading the personal space of other residents, but then the staff were invading his space. And just like Dr. Jurovich mentioned, just touch can be simply a trigger, especially if it's done in an inappropriate way. Misinterpretations of staff intentions. Go ahead. Sorry, I probably shouldn't have animated the slide the way I did. And then mirroring. I'm not sure if any of you are familiar with this concept of mirroring, but if we're having a bad day, that in someone who is not able to kind of filter and understand and perhaps ask questions may mirror your bad day. And if you're kind of angry and irritable or reserved, they might mirror that behavior. And it's, again, us having a bad day and not checking our stuff at the door, which is actually causing the behavior and the patients and the residents that we're working with. Next slide. So this is an idea strategy. So ID, identify the behavior. So what is the behavior that's difficult for you to deal with? Be specific. Again, don't just say that they're agitated. Describe the agitation. Can you see it? Does it bother others? When does it happen? Who's around when it occurs? Then you want to explore what might be causing the behavior. Understand the cause. Is it a health issue, an environmental issue? Is the task too difficult, or are there too many steps? Is it a communication issue? And then you want to adjust what can be done. So you're going to be the one that needs to change. The person cannot. So again, it's incumbent upon us. While we may perceive them as problems, they're problems for us, but it's really their unmet needs that we have to identify. Next slide, please. So you got to do some adjusting, get creative, address what's causing the behavior, keep tasks and activities simple, keep the home as calm as possible. You can read through a lot of these, but one is be present in their reality. Don't argue, kind of agree and comfort the person where they are, whether it's right or wrong. Just be present in their reality, because that's very real to them. And find meaningful, simple activities so the person isn't bored. Give them a sense of meaning and purpose. And again, if you're having a bad day, check your issues at the door, because it's only going to make work worse. And distract or redirect. That can be a really key and effective strategy. And accept the behavior. And understanding, I had this one woman who every night at 5 o'clock, she felt that she lived on a ranch, and there was a herd of horses that would come through her room at 5 o'clock. And the staff thought that was really upsetting. And they, consulted me thinking that she needed some antipsychotic to manage this hallucination. And the woman didn't find it distressing at all. She actually thought it was enjoyable. And she had this interesting clinical syndrome called Charles-Bonnet syndrome, which is kind of a psychosis that can be result from visual disturbances. So she had macular degeneration, so it caused her to misperceive some things in the environment. But, in turn, we realized that this was something that we should accept because it wasn't distressing to her. It wasn't causing any problems. So again, you all get this stuff. That's great. So exactly, all of those are potential triggers for dementia, for behavioral symptoms. Okay, so revisiting Mr. Jones. So what ideas did we learn? As we kind of tried to track down some family and figure out, what he did for a living, it turned out he was a nighttime security guard for over 30 years. And he was used to being up at night. And so his agenda or need-driven behavior, his checking of the windows and rooms was what he was always used to doing at night. And so I, challenge us to think, is it fair, appropriate to make him to adjust to our facility routine from a very medicalized, institutionalized language approach? Is it fair to make him adjust to our facility routine after 30 years of working night shift as a security guard? I don't think so. Next slide. So what we did is we fostered a sense of dignity and personhood. We gave him a sense of meaning and purpose. We gave him a security badge, a badge that he could wear, and a clipboard. And go ahead, Chris. And then what was great was, so every night when the nursing staff were doing their evening meds, he would go round with them, and the nurse would go in and give the meds to the resident and come back out, and he would check off on the actual clipboard. And once she did all of her rounds, he put down his badge, put down his clipboard, and he knew his shift was done, and he went to bed. We got rid of all antipsychotics, all sleeping meds, all antidepressants, and he had a new sense of community. He felt like he was contributing, and it was just the smile on his face. He felt like he was Superman, and it was fantastic. Yes, exactly. Give him that job. I agree. As Molly was saying, when family's available, they can be a great resource for information. And yes, and Linda, a sense of purpose. We all need that. Okay, next slide. So the principles guiding treatment. Knowing a person's baseline and who they were prior to the dementia taking over their brain is really essential. And remember that something can always be done for persons with dementia, no matter what stage of the disease they may be in. And that behaviors represent understandable feelings and or expressions of needs, and factors that cause excess disability must be identified to improve function and quality of life. And again, we can't expect the person with dementia to change. We must get creative and come up with the ideas. Use that idea strategy that I shared with you. And of course, don't forget to consider the impact on the caregivers, both the staff and the family, because that's really important, because it can be challenging, and we don't want to discount that. As much as I'm empowering you to kind of get creative, it can take its toll. And so I think it's important to support one another. All right. 100%. Great. Next slide, please. And I always like to end with a strength-based approach, that wrinkles should merely indicate where smiles have been. Next slide. Thank you, everyone. And I've also listed some resources for additional information. Sorry, it's super small. I think Chris, thank you, Chris, for putting them in the chat. Just some additional resources that you all can tackle, but thank you all for letting me be a part.
Today, as Linda said, we'll be talking about step 6 of the awareness campaign, or of our QAPI steps, and that is really looking at our QAPI awareness campaign and communication about QAPI work. Just a reminder, I'm Adrienne Butterwick. I'm a Senior Improvement Advisor with Comagent Health based here in Utah, and I am joined today by my partner, Jean Lyon, who is a clinical care practitioner and Senior Infection Prevention Advisor at Comagent Health. Next slide, please. So just a quick recap from last week. Last week we talked about building your QAPI team and ensuring that you have all of your elements in place. So if you, we would love to hear if you've made any progress in your QAPI development. I believe we asked at the end of the last session, if you could take a look at the composition of your QAPI team, make sure you have representation from all the different areas within your nursing home, and make sure that you are actively inviting members from areas that may not be already incorporated. So please go ahead and share with us in chat if you are if you have anything to share about the presentation last week and any changes you may have considered about the composition of your QAPI team or your plans.
Talking about today is taking the time to create a deliberate communication plan. We know that leaders are the individuals who make sure that people have the tools that they need to get the job done. Without leadership support, your quality improvement program really has very little hope of success. Ensure the scope is kept to the QI focus and manageable for existing workloads. And the sixth action step focuses on communicating with two focus populations, the caregivers and the residents and families. Let's go to the next slide. So we know that we need to make sure that residents and families know that their views are sought, valued, and considered in facility decision-making and process improvements by announcing and discussing the QAPI in resident and family councils and other venues. You need to remember to ask residents and family members to tell you about their quality concerns. Many facilities today are using some type of customer satisfaction survey. Results could be used to identify opportunities for improvement and will proactively have an impact on all residents and their families. To try to view concerns through residents' eyes is very important. For example, getting back to a resident in 10 minutes may seem responsive, but may feel like an eternity to the resident. How would that feel to a resident waiting an answer to a call light for help to the bathroom? 10 minutes might be too long. It might be too late. Convey the message that QAPI is about systems of care, management practices, and business practices. Symptoms should support quality and or acceptable business practices, or they must change. Use examples to get messages across and ask caregivers to think of examples of their own. Be sure that your consultants, contractors, and collaborating agencies are also aware of your QAPI approach. Maybe you have several hospice organizations coming in and out of your home. You may work with a podiatrist, for example, who comes in regularly to provide services. They all need to know that they have a role in your system and convey the message that any and every caregiver is expected to raise quality concerns, that it is safe to do so, and that everyone is encouraged to think about systems. And back to you, Adrian.
Thanks, Jean. And next slide, please. So as this is an active ECHO series, we wanted to make sure that we are sharing with you. Oh, thank you, Christopher. Wonderful. You guys are so on top of it. So this is the link to the HSAG, which is the Health Services Advisory Group. They have a resources that are really complementary to the QAPI at a glance PDF that we've been using as a resource. So I wanted to just include this as well. It's just a nice checklist that helps you kind of make sure that as you're building your QAPI plans, that you are ensuring that you're reaching all of these other groups in your communication. So there are other different checklists and tools at that link, but it's just a nice way to kind of help you make sure that your strategy is really reaching all different areas, not just residents, families, and caregivers, but also, as Jean mentioned, really anyone that comes into your building, anyone who works with your residents or your staff is someone who should understand and be open to sharing their input and thoughts on the work that you're doing with quality improvement. I think oftentimes we find some of the most creative and innovative ideas and solutions that come from people that are outside of our regular teams or groups that we're more familiar with working with, excuse me. So it's nice to have that kind of wild card open pot, if you will, of having other information and other sources of people that can contribute to your quality improvement work and also help you identify patient safety in other areas, issues in other areas more quickly and effectively. The answer, I'm guessing you guys are all rock stars and got it. Yes, excellent. You know, staff is kind of the tip of the iceberg when it comes to this information. So keeping them in mind is important, but we need to be sure that we are including everyone. Really, anyone that comes into your building is a part of your culture and can really contribute to your quality improvement success. So I did want to take a moment here. We have Jerry Olson, who's the administrator for the Southern Utah Veterans Home in Ivins, Utah. And Jerry and his team have been doing some really great work in communicating their QAPI work within their building and within their residents and families. And I wanted to give him an opportunity to share with us a little bit about their experience and things that they've learned along the way in their QAPI awareness. So Jerry, if you are on the line, I believe I saw you earlier. Please go ahead and unmute. We would love to hear from you.
Can you hear me, Adrian?
Sounds great. Thank you.
Awesome. Okay. Well, I had understood to take about 5 minutes, so I can quickly do that. Thank you for the opportunity to say something. We love QAPI here at our facility. And I'm glad you talked about the QAPI plan, because everything I had made in my notes here refers back to our QAPI plan. I'm just going to give 5 or 6 quick kind of action items of things that we have actually done in our facility that we found to be effective as far as raising QAPI awareness and increasing staff and family and resident engagement. Some of these issues I'll talk a little bit more about, and some of them I'm just going to quickly mention. First one is that we have been able to get our entire leadership team QSP certified. I guess it's QCP, QAPI certified professional through ANAC. We have about 30 of our leadership team that are certified in QAPI, so we're very proud of that. As part of one of the campaigns we did, we had a t-shirt made. It's a Star Wars theme t-shirt. It's a black t-shirt with gold lettering, and it says the best QAPI in the galaxy. And we did some training for our staff, and we gave out a number of those t-shirts. We made them available to all of our employees, actually. And that's been about 3 years ago, and I still see those almost every day here at work. The third thing we did was kind of a big one, something I'm really proud of. It wasn't my idea. It was our QAPI coordinators, who is Nancy Boyer, our health information manager. She came up with the idea of having a calendar. So we went through a local printer and we created a custom made calendar. And I think it ended up being about an 18-month calendar. It's going to end at the end of 2022, and we'll come up with a new one. Each month has a different QAPI theme or QAPI topic. Some examples are very simple items such as our vision or mission statement. One month, the QAPI theme is root cause analysis. Another month, the theme is systems thinking. Another month, the theme is just culture, and I could go on and on. And so what that does is that means throughout the month, all of our department managers and leadership teams should be talking to their employees about the theme for the month and discussing it and raising awareness with their employees. And we also had a whole bunch of these calendars printed. Actually, we ended up having too many printed because this was the first time we've done this. We gave them away to family members, to residents. Every nurse's station has one of these calendars. They're all over our facility. We actually now have a stack of them in the lobby. Anybody who wants one can take one. So anyways, we felt that's been really, really successful because it sort of gives us a topic of the month. The next item we did is very similar to that. We created a brochure. It's a simple trifold brochure from QAPI at a glance. We took that document and we boiled it down and took what we thought were the key pieces of that we would want our family members and our residents to understand. And we created a simple, it's very slick, it's actually very professional trifold brochure. And the title of it is Quality Matters, Information about Quality Management at the Southern Utah Veterans Home. And we passed that brochure out in IDT meetings. We will pass it out in resident council a couple of times a year and talk with the residents about quality. And it's really just kind of an all-purpose brochure. The thing that I thought was probably one of the best things we did is once we created a draft of this brochure, we formed a focus group. We invited all of our family members. We sent out an email to everyone and invited them to participate in the focus group. We rented a conference room at a local hotel. We had lunch brought in, and we put the brochure up on the screen and went through it point by point with our family members, which not only educated them on QAPI and what QAPI is, but we were able to engage them and obtain their feedback, which was it's been a great thing. So that's one thing. Another thing we did, and then also just two more, and I'll be done. We share our customer service survey results with our line staff. That sounds basic, but it's a little scary sometimes. But we do that. We take them all, we redact anything out that would be super embarrassing, or we redact out all the HIPAA, information. And we have a system where we share those results with everybody in our facility. We also have a system where we give rewards to folks who have their employees who have their name mentioned in those surveys. So we're just trying to celebrate positive. And then the last thing I was just going to mention is we actually have, this is something we've tried recently that I thought was a big, huge success. We don't invite our residents to QAPI meeting, our monthly QAPI meeting, because our attorney won't let us, and we don't want to share protected information and pierce the attorney-client, privilege veil. But we had what we called a resident quality meeting, where we just had, we're a veterans home, so most of our residents are men. We had them all come in. We had some coffee and donuts, and I sat down with them in a circle, and we educated them on what the quality measures are. And I got on my computer and we put it up on a big screen, and we went through Nursing Home Compare. We talked about what our metrics are, how we compare, and honestly, they loved it. The number one thing that we struggle with is falls. Our building is very big and spread out, and for some different reasons, we have way too many falls. So it was a chance for us to explain to them why and talk to them about, how they can help us, and we as a community can improve our, our metrics. But I think it helped them feel included and important to hear that information, and it was a home run. So
scanning through some of the comments here, it's Christine mentioned that it feels like when they involve family with the care plan meetings, they spend a fair amount of time as educators about their diagnosis and how to interface with that. So you do have to keep in mind, opening that door does open the door to whatever comments people are open to share with you. But that really does speak to your culture, and having an open door policy, and really being open to hearing all the feedback. But just a note to be prepared, to get that broad spectrum of feedback.
Hey everyone, I just thought I'd toss in some culture change, piggyback on what Jerry just shared. Jerry, can't agree with you more. In fact, a word that could be tossed into the mix, everyone, is being more proactive. If you want to be excellent, we recognize that sadly in long-term care, we've been very reactive. And another thing to focus on would be being proactive. In fact, I do a lot of teaching on proactively preventing falls. If you switch the mindset, speaking of falls as well, guess what, everyone? Involving residents and families and QAPI has been a culture change practice. Of course, the elements that you can include people in. In fact, that led to community meetings. Daily community meetings have become a place where you can talk as a community about things that are happening in real time. Homes that do it don't even do monthly resident council. I think of it as collecting everyone's ideas, whatever's going bad or good, and your ideas for making it better. I say, go crazy, everyone. It's the only way. Having been a surveyor, you got to ask the questions before someone else does. You got to ask the questions before the surveyors do. Another neat thing that fits right here is another culture change practice is family councils. In future trainings, I could bring up the Artifacts of Culture Change tool because it actually represents all of these things. And back to words, we purposely don't say rounding. How do you like this, everyone? Proactively checking in with residents. an example of how words have power. And so just like those negative words about being old make people walk slower, it proves, I'll take the next slide, please, that language has power. And I'd like to try something with all of you. I'm going to be quiet for 30 seconds or less. And I'd like each one of us to say these words out loud, even if you're in a group with other people. We're going to do an experiment. I've never done this before. I'm going to go quiet. I'd like you all to say these words out loud. So you're wanting to think about what's the feeling you have, and could you put that in the chat box? What's the feeling? What's the atmosphere? What's the culture from those words? What's the power of those words? And next slide, please. There's power in these words as well. And if you would please just do this experiment with me, do it again, say them out loud to yourself and see what feeling people say everyone are seeing is medical jargon, medical model, labeling, cold, uninviting. Oh, Cindy's saying they're naughty words now. Just have fun with that, everyone. Be careful. Business words, institutional. And then how about the other words? Let me go back. Sorry. Friendly, inviting, positive. Yeah, thank you, everyone. I've actually never done that before. It was just a true experiment. I'll take the next slide, please. And if you want a resource, we did a white paper called The Power of Language to Create Culture. I got to do it with Judah Ranch. He's actually a PhD in linguistics, everyone, and one of his master students, Galina Najarov. And that's available for free at my website or Pioneer Network. And someone's saying my favorite was nurturing home rather than nursing home. I'm glad you brought that up, Christine. I'll tell you why. One of the leaders in our movement also makes fun of the title nurses station. She says it's not a nurses station, it's a nervous station. And so you really can have fun with words, can't you, everyone? And make a point. Next slide, please. And I think that should be it. So guess what? We all have the superpower of language, you and I. So you can change institutional culture, you can create positive, you can create a different culture if you want by moving over to some of those different